Okay. Assalamu alaikum. My name is Shayan Mercia, and I'm currently an intern at Civil Hospital Karachi, having graduated from Dow Medical College from the batch 2020. Today, I've had the utmost honor of interviewing two of the most inspirational people amongst many that Dow Medical College has produced in the past few years. One of them has been my mentor in my profession, in my life, and whatnot. So it's my complete honor to introduce Dr. Shahzeb Khan. Shahzeb Khan graduated from Dow Medical College in 2017, in 2016, I'm sorry. And right now he's a clinical instructor at the University of Mississippi. He will be NIH funded researcher with a T32 grant, and his research amongst other sections of medicine focuses primarily right now uh, to the clinical trials conducted during the COVID-19 pandemic and management of heart failure. Dr. Shahzeb has done his residency from the John S. Stroger Cook County Hospital, Chicago, and I've had the utmost honor of working with him on multiple research projects. So thank you, sir, for joining in. The other guest is again a very dear friend of mine, a senior of mine, and not just me, but hundreds and thousands of medical students around the entire city, or perhaps even beyond that, have learned how to manage basic trauma or how to manage basic life-saving skills. Dr. Haris Sheikh graduated from Dow Medical College in 2017. He is 1 year junior to Dr. Shahzeb. He right now is currently a resident at AKU for anesthesiology and critical care medicine, and he has been the ex-president of First Response Initiative Pakistan, which is a student-run organization that Dow Medical College has. Dr. Haris has changed the surface of basic trauma management when it comes to Karachi and beyond that. And thank you very much, Dr. Haris, for joining us in this session.
Thank you for inviting us.
So this session primarily is very dear to me amongst all the sessions that we have done, because this session is going to debunk the myths and the taboos that are surrounding the COVID-19 pandemic. The COVID-19 pandemic is an unfortunate incidental arena of this year, or perhaps even this century, that our world, the Mother Earth, has faced, and hence आप लोगों को पता होगा, literally हर platform पे there are multiple sessions going on to aware and to educate the general populace about how to contain themselves in this pandemic, or perhaps how to even rejuvenate after this pandemic. So I've taken the pleasure of introducing two of the most known people in this city to talk about this pandemic. So I'll just start in a light-hearted manner, and I will just ask, because both of you are in very different forms of clinical practice. One is in a different country, the other is facing tremendous circumstances in our city. So I'll start with Dr. Shahzeb. Sir, could you just enlighten us what has been your most potent incident or an anecdote that you have faced in the past 3-4 months with this pandemic?
Thank you, Shan, for the wonderful introduction, first of all. So in our hospital, we started the COVID floors around March or February. Initially, we had 1 COVID floor. Then ultimately, we had to create 5 COVID floors. I was on the COVID floor for 1 month. We used to admit around 10 to 15 patients, I would say, every day, my team. Obviously, ED would admit a lot of patients to the other teams as well. So from those 10 to 15 patients, I would say I would send 2 to 3 patients to ICU every day. Our ICU covers around 40 to 50 beds. All the beds have ventilators. So when I would try to send patients to the ICU every day, the ICU would say they don't have any beds. So literally there would be 3-4 patients on the medicine floor who would be on 15 to 20 liters of oxygen, 100% FiO2. Like, for example, right now we are breathing 21% oxygen. They would be on 100% FiO2. They would be on 15 liters of oxygen, but they won't have a bed. All the beds would be full. So then we'll have to triage, like, which patient should we send to the ICU. So those decisions were really tough for us. I mean, I would be managing like 4 or 5 patients same time on the floor who would be on so much heavy requirements of oxygen. And then we really have to decide which patients to send to the ICU. So those decisions were really tough. Similarly, when I was serving in the ICU, we had 40, 50 patients of COVID every day. almost 90% would be intubated on a mechanical ventilator. There would be 6-7 codes. In layman language, code is when a person loses his pulse, so we have to revive those patients. There would be 6-7 codes at the same time. So you don't know what to do. The nurse would call, like, there would be 6-7 patients who would be desaturating. Just the oxygen saturation is going down at the same time. And then there will be there's a special type of ventilator known as INO ventilator, inhaled nitric oxide ventilator, which also has very limited availability. It's super expensive. So I think in our hospital there are 10 to 15 INO ventilators. Again, patients would be crashing, so we'd have to choose which patients should be put on INO ventilators. So again, those decisions were so tough. Again, this was extremely emotional during the whole time, because there would be, for example, there would be a patient whose wife would be in the next room also intubated. Similarly, we would admit a patient. Unfortunately, he would die, and then in the next 1 week, his wife would also be admitted and would also die. So these were really like emotionally draining experiences.
All right. So the same question to Dr. Harris. Could you just enlighten us with a story or an anecdote or what's happening in AKU right now when it comes to your specialty?
Yeah. Thank you, Shan, for inviting us and for the inviting introduction. So basically, my job as an anesthesiologist is more specifically towards critical care, ICU management, and the crashing patients, as Dr. was talking about. What I'm doing these days is rush call duty. So basically, if I would explain it in layman terms, rush call is basically whenever a person crashes and is in need of an advanced airway, I have to go there and put a tube in their throat so that they can breathe, and a mechanical ventilator could be attached. This has now become more of a consultant-based job because obviously the guidelines all over the world state that the most experienced handler should intubate a COVID patient, which is most of the times a consultant. But still, in the early days when we started off in, I think, end of Feb and March, beginning of March, we used to go on rush calls and intubate patients who were COVID. And so I went to intubate a patient who was COVID positive, and yeah, because the circumstances are such that patient is crashing, he's on high oxygen demand, he's gasping for air, and obviously there is a sense of impending doom. So you have to like tell the patients to calm down and everything would be all right, even though sometimes you know that they might not come back from this particular experience, and sometimes you know that you might just be the last person they're speaking to right now. So that was kind of a very emotional period of time. Still, we are intubating a lot of COVID patients, and obviously the same stuff happens every now and then. So yeah, this particular thing, telling the patients that everything would be fine and that you would come out of this, is takes an emotional toll on all.
To the point of no return. That's really touching. Thank you very much for sharing that, Serge. So I'll just indulge into the more general questions to just aware the general public, and let's warm up on that. So one of you could take one part of the question. So the general public would like to know that what are the typical and the atypical symptoms that one can incur, चाहे किसी भी age group में हो, when they might get COVID infected. So Dr. Harris, you could take the typical symptoms, and Dr. Shahzeb, you could tell us about the atypical symptoms.
Yeah, so the disease follows either an asymptomatic or symptomatic pattern, and even in the symptomatic pattern, there could be like normal symptoms and there could be severe disease. So either a patient could get infected and he can have no symptoms at all. Like you wouldn't know unless you get tested for PCR. But if you get symptoms, the commonest symptoms are fever and cough, followed by a sore throat, and it affects all of the other systems. And so you could get diarrhea, you could get body aches, you could get febrile. These are sort of the basic symptoms that we see mostly in the clinical practice. I think Dr. Shahzeb can highlight more of the specific symptoms of COVID patients and severe symptoms as well.
Ji sir, atypical ones.
So a very common symptom, in fact, it's an atypical symptom, but very commonly seen is anosmia. In fact, I had a few of my colleagues which were COVID positive. They had no symptom whatsoever except they just couldn't smell anything. Similarly, loss of taste. It's a very common and atypical symptom that uh, a lot of my friends who are completely normal when they were COVID positive, except don't go, just couldn't taste or smell anything. Uh, Sometimes COVID can just cause extreme fatigue as well. Due to inflammatory reaction, they might not have any fever, they might not have any other thing. They must, they might just be super fatigued. Uh, I would say COVID can cause anything, literally anything. I mean, so the first suspicion should always be COVID in the current day and age because it can literally cause anything. I've seen it cause stroke, I've seen it cause lung clots, I've seen it cause leg clots, it can cause heart failure because when the body is having a severe inflammatory reaction, it can affect each and every part of the body. It can literally affect any part of the body, kidneys, heart, brain, anything literally. So the first, I mean, if you have an exposure to COVID and if you're experiencing weird symptoms, COVID should always be ruled out, regardless. I have seen patients who are completely fine. In fact, I was just recently hearing about an incident. There was a teenage guy who went into heart failure just because of COVID, myocarditis. So literally, COVID can cause any range of symptoms.
So we probably consider it as one of the most deadliest organisms to have infected Mother Earth for now, I think, given if we bar the Black Death in the 1500s, wouldn't you say?
Yeah, rather than being deadly, it's more of an uncertain situation right now because we don't know what's going on with the disease. कुछ लोगों को बिल्कुल भी अफेक्ट नहीं करती. They are asymptomatic and कुछ लोगों का symptoms appear होने का graph is so severe that they get CVSTs and blood clots like Dr. Shahzeb was mentioning. So yeah, it's more of an uncertainty right now. If you look back like 5 years down the line and see कि क्या था disease में, so we might not say the same words, might not use the same words for this particular disease. But yeah, right now you could say that it could be one of the most deadliest.
So as you mentioned that ये कुछ लोगों को affect नहीं करता या करता है, could one of you just shed light कि हम ये कैसे समझाएं आवाम को, because I don't know how I should say this, but both of you might have the liberty to work with people or to treat people जो कि शायद समझ रहे हो, but from where I come, civil hospital में it's become so difficult to make people understand, the patients and also healthcare professionals alike, that भाई ये कुछ लोगों को affect नहीं करेगा, कुछ लोगों को करेगा, so don't hold us accountable for that. Hello.
Yes, I can take
Yeah.
this. I can take this one. So I think it is very difficult for the people to understand, to be really honest. I mean, even for doctors, sometimes it's mind-boggling that what is happening. ये हो क्या रहा है? I have seen 80, 90-year-old patients with all of the comorbidities getting COVID, and they're completely fine, absolutely fine. Then on the same time, a 20 or 30-year-old guy will get COVID, and he will end up in the ICU on a ventilator. So even sometimes we don't have the explanation. So it is extremely difficult for the layperson to understand what the hell is happening, to be really honest. So at this time, I mean, the only thing that we can do is try to convince people, try to understand, try to communicate the message as clearly as possible. Another thing that I've really seen is patients who are admitted in the hospital because I'm assuming visitors are not allowed even in Pakistan's hospitals. So in
Yeah,
US,
they're not.
visitors
They're
are not. So I think one of the very important things that we as physicians should at least do is we should uh, call the family at least 3 times in a day to update the patient. Because sometimes what happens is the patient, we know we are doing everything for the patient. We know that we are doing everything for the patient. Sometimes that thing is not relayed to the patient's family. They think क्या हमने patient hospital गया था ठीक ठाक था 2 दिन के बाद एकदम से he's on a ventilator. So what happened in between? So as physicians, I think the communication is the most important part. As I initially said, I think it's very difficult for a layperson to understand.
Right.
If यही कर सकते हैं कि
Alright.
just try to hammer in the message.
Acha.